Welcome to the eJournal Club. I wanted to review a couple of articles that are linked and connected that I read on a very new, interesting concept of a new way of stimulating the brain using the deep brain stimulation surgery or DBS device for Parkinson's disease. Now, the DBS itself is pretty old concept. It's been going on since 1980s. Is FDA approved for tremor in 1995, for Parkinson's disease 2002. It is very commonplace. There are more than 150,000 patients in the world with Parkinson's disease who have had the deep brain stimulation device placed in. And stimulation is a commonplace thing. In University of Nebraska Medical Center, we have over 300 patients that we follow for the programming for DBS, and we have about 40 to 50 surgeries that we do every year, and it's increasing and would be increasing in future. But there is a new technique on how you can stimulate the brain that seems very exciting. So I wanted to share this paper with you. Um, my name is Danish Bhatti. I'm a movement disorder neurologist at University of Nebraska Medical Center, and this is an eJournal Club. So to give you an idea of what I'm talking about, if you have no familiarity with DBS itself, before I come back to this paper, I would show you that I'm talking about this device here, which is called the deep brain stimulation device. Leads are placed, which are called electrodes, into the brain, in the deep part of the brain, a specific area that you want to stimulate, such as subthalamic nucleus. And the wires come out, run under the skin, behind the ear, go down to a battery in the chest, which you can control to stimulate the brain. Now, the lead stimulation is a little bit technical, but the idea is that the tip of this wire has these four kind of contacts numbered either 0, 1, 2, 3, or 1, 2, 3, 4, or 9, 10, 11, 12, differently by different companies. But if you turn on the current in one of these contacts, there is an electrical discharge coming out, or electrons coming out from this lead, going out into the tissue around it, usually a few millimeters of a tissue, and that stimulates it. And what you can do with that kind of a bubble of electricity is that you can increase or decrease the size. You can make it more frequently pulsing or slowly pulsing, and you can increase or decrease the duration of each pulse. So let's say they are increasing pulsing, but they're still increasingly pulsing, but they are staying on longer, or they're staying on shorter and are pulsing about the same speed. So you can change these three factors. That kind of, you can see one of the programming device here that is showing that pulse, and you can see the volts here, or voltage, which is the 2.3 volt listed here, and you can also see the frequency 130 hertz, and the pulse width is harder to see here, but it's probably about 90 microsecond of the pulse width. That is how long each pulse stays on before going away. So that's a traditional method of stimulating. So what traditionally we do is that we can increase or decrease the size of the pulse. We can change the contact we were selecting. We can increase or decrease the bubble, and we can change the frequency of how frequently it is pulsating. But whatever setting we end up with, what is happening is that the pulse are constantly just humming along. So once the programming is done, patient goes back home, the pulse is constantly on and constantly going on at that frequency that you selected, and at that pulse width that you selected, and the contact that you selected. So it's just constantly going on in a regularity. Now, what this paper is talking about is to use what is called a coordinated reset neuromodulation for Parkinson's disease. And before I explain you what coordinated reset neuromodulation is, let me introduce one more concept. So this coordinated reset modulation, to understand this, what we need to understand is that what's going on in the brain in terms of electrical signaling that we're affecting with our device, with the DBS. So what we have found out is that if you listen to the brain electrical circuits themselves, and see the electron firing, the electrons fire randomly, creating multiple waves. But if you look at it from a bird's eye view of all that electrical firing going on, you can start seeing kind of an overall waves or patterns form and disappear and form and disappear. So let's say multiple different discharges creating one large wave, and then it's gone. And overall, these waves also have a frequency of how often they're happening, and these frequencies can be as low as 1 or 2 hertz, or 1 per second, 2 per second, to all the way up to 100 per second. But they randomly happen. So most often, the brain's electrical firing in that area which are we are stimulating with a DBS in a normal healthy adult is what we call random, irregular, or asynchronized. There is no regular rhythmic wave or standing wave that you can see. There is no, there may be random waves, but there's nothing standing there. But what happens in Parkinson's disease is that there seems to be buildup of activity around what is called beta band, which is about 20 hertz. So right about at 20 hertz, you can see that there is kind of a formation of this wave-like activity, which is showing up just an increase, a peak in activity detected. So if you plot the wave at different frequencies in the brain, going from 0 all the way up to 400 here, you will see right around 200 there is a peak or a discharge of the activity. Most of the brain activity is around below 50, but it's kind of smoothly distributed unless there is a patient who is in off state, which is blue here, and you'll see this beta band. And what happens when they are in treated stage, either with medication or with stimulation, the wave disappears, and you can see in green the on state where the beta band has disappeared. So this beta band oscillation has become kind of a hallmark, a measure in the brain of Parkinson's disease symptom, and it correlates with the response to treatments or disappearance of symptoms. So the patient gets better with medications or stimulation, the beta band disappears, and the beta band comes back if the stimulation goes away or medication wears off. So that got a lot of scientists interested in how can we make our therapies optimized so that that beta band, the standing wave around that 20 hertz that is present in Parkinson's patient, is not present. And are there better ways of doing it than what we are doing right now, which is that if we do this simple continuous stimulation, the beta band does go down, and that's a way of telling that therapy is working. But is there a better way of doing it? So another kind of picture on the beta band, you could see the beta band forming in blue here, and then disappears when the therapy works, then comes back when therapy disappears. So this brings us to this concept of coordinated reset neuromodulation on this paper on proof of concept. This is published in 2014. They're talking about a new method of specifically targeting the beta band oscillation, and see if you make the beta band oscillation go away with this method of stimulating, which is unusual or new, will that be more effective, more helpful? Um, this is done by Dr. Peter Alexander Tass and his team. And Dr. Tass is in the Institute of Neuroscience and Medicine Neuromodulation in Germany. And and actually, he did a work earlier in monkeys in 2012, which he published, where he did the first concept testing in monkey model of Parkinson's disease using MPTP. And then these monkeys had the stimulation placed, wire placed, who have developed Parkinson's disease, and then they had the stimulation done in that kind of a coordinated reset mode with low intensity, with high intensity, and then the classical stimulation. And they already found a difference that the monkeys did much better with the low stimulation coordinated reset one. And the most interesting thing that they found was that if you turn off regular stimulation, the benefit goes away pretty quickly. Uh, but if you, so this is if you look at this graph F here, you will see that there is MPTP lesion per monkey. There is acute effect of treatment, and then it's just gone. There was some effect, and it was just went away. And then if you do this coordinated reset modulation method, but use high intensity, which is the actual DBS like intensity they were originally using, then you get benefit, and there is some sustain of the benefit on day 1 to 5, but then again it goes away. But if they use the low intensity coordinated reset, the graph E here, then you can see there was a great benefit right after stopping the treatment. And the benefit continued for days after, all the way up to 35 days or a month after stopping the stimulation. There was still noticeable, measurable benefit in symptoms of monkeys after stopping the stimulation. So this is amazing. So imagine that the monkeys have been stimulated for a couple of hours, and then the stimulation is off, but the effect of such a stimulation is lasting 35 days in monkeys, which is amazing. This is unbelievable. Right now when we're stimulating constantly, and the battery is draining gradually from that battery in the chest. And in 3 to 5 years, depending on how much current they need, the battery is gone and we need to put a new one in, or we need to put a rechargeable in. But imagine if you have to stimulate just one day or 2 hours a month, and how long the battery will last forever. You will just not use that battery and never run out. So based on that work, they actually did a proof of concept on humans. Now, the battery that currently is on the market does not have the capacity to do it. So what they were doing it in monkeys was to use a laptop, a software in a laptop, and they had to do the same for humans. So what they did was that once the wire was placed in the brain, it is common for us to wait for 1 week before we put the battery in the chest and run the wire into the skin to connect to the battery. So what we do typically during that 1 week is that we leave the wire as we leave the wire kind of as coiled under the skin, tucked under the skin. We make a pocket under the scalp, and we just leave the end of the wire here under the skin. And then when we do the next surgery a week later, we open this back up, get hold of that wire, fish it under the skin behind the ear, and then bring it to the battery and hook it up. So what we do in these kind of studies where we want to use a software capacity from a laptop or a computer desktop, which is not available in the battery device here, is that we, rather than leaving it under the skin, we externalized it. We bring out the tip outside and then close the skin around it, and then use it for a few days until they are ready to have it placed with the battery. Now, of course, you have to clean it very carefully and very thoroughly before putting it back in, so that to avoid infection. But that will be the main risk of doing it, that the skin wound can get infected, or the wound on this, or the lead can take the germs back in as you put it back in. But we with good septic measures, that can be avoided, and this is something that has been done before. So that's what they did. They basically took 6 patients with Parkinson's disease, and they externalized their wire, and they did this kind of stimulation. So what the stimulation actually was like, before I come back to the benefit, is, let me show this in the supplement here. Um, let me see if I can find that supplement. Um, Let me grab that paper. Sorry. Here we go. So this supplement here basically is kind of going through the details, and let me just jump to the figure here. So this is what is the coordinated reset neuromodulation. So what they're doing is that they're giving brief pulses of current. So this individual pulse that you see over here in contact 1 in this first segment here is very similar to the normal stimulation that we do, except that it is very short. So in a normal stimulation, this kind of lines will continue throughout the chart here as a constant stimulation. But what they're doing is that they start the stimulation, give 3 to 5 trains and stop, and then they give 3 to 5 in a second contact above it, and then another one below it. And that 3 contact stimulation creates one cycle. Then they repeat the cycle but change the pattern. So rather than giving it in contact 2 as second, they give it in contact 3 as second, contact 0 as second, and then they change it again in the third cycle. So they do 3 cycles with 3 different variations. So it creates this large block of these random stimulation going between these 3 contacts, rather than a single contact use, which is typical of a normal stimulation. And then they take a pause, and they actually say that the pause seems very useful to allow the brain to develop that desynchronization that's required rather than creating a new synchronization. And then after that pause, they do it again and again. This is now randomized again to look different than the first 3 cycles. So 3 cycles on, 2 cycles off of these trains of 5 stimulations. The train itself, that sharp, that small piece, is very similar to what a normal stimulation will be continuously, but that pieces are then given randomly above and below it, in a different arrangement, and then it's done for 3 cycles, and then you stop for 2 cycles where there is no stimulation at all. Then you do 3 cycles again. Now remember, these cycles are very short because the distance between the two uh, segments or trains within a cycle is also very small, is in a millisecond. So the 1 cycle is completed within a millisecond, and the whole 3 cycles is given. So 3 cycles with a pause, and then 3 cycles with a pause. Many of them can be given within a second, and it's going on randomly so as to throw off the neuronal synchronization that has happened in beta band, which is causing the symptoms of Parkinson's disease. And that's what the coordinated reset neuromodulation is. And what they found in the paper, if I go back to the paper here, is that the patients were tested in the morning, day one after the surgery, off medication, off any stimulation, and they recorded their baseline Parkinson's scores and ratings, and they found that after the stimulation, the patient were much better. And the stimulation was less than 2 hours, so on average about 1.6 hours. And then they were not stimulated anymore for the rest of the day. And then the next morning, they were still better than their baseline before. And then after stimulation, they got even more better. And then after 1.5 hours, there was no further stimulation or less than or 2 hours. And then they stayed off medication and stimulation overnight, and then the next day were even better. So they found that on 3 days of testing, before and after stimulation, each day was getting better and better, and then the after stimulation was of course better than before stimulation. And they found this improvement for all 6 patients. They looked at the group averages, and the averages were better. They looked at the scores on tremors, and the tremor scores were 64% better. They looked at this rigidity and bradykinesia of Parkinson's disease, and that was 63% better. And they found that and they looked at the local field potential before and after, and they found that beta band did disappear after this kind of stimulation, and over time, as they were hoping. With this kind of a coordinated reset modulation. So there are numbers and details here that I will skip, but I was just really excited about this new concept of method of stimulation, which is a lot of potential. There are already pauses and there is a lot less amount of stimulation per second with this method of stimulation. So that will save battery, but it seems like it can have long lasting effect even if the stimulation is turned off, and there is a cumulative benefit over time, and may be able to provide benefits to symptoms that don't traditionally respond to stimulation, such as speech defects or freezing or hesitation. It may be that you could find newer coordinated reset methods or algorithms to try to do even better. I think so. This paper is 2014, 6 years old already. There is already devices in production that are developing this capacity within the battery that is implanted to the patient, so that you don't have to have a lead hanging out for and only do it for 2-3 days, but you can start studying it in the battery. You can do it much longer time and have much more kind of evaluations done to see how useful this kind is. And then and to be able to do that, they have advanced that battery, so that battery not only stimulates the brain but can also sense the brain and can do this local field potential from the wire itself, and it has a software that can then analyze it. That's a significant advancement in the capacity of the battery, and then gives us a lot more tools to play with our patient. I hope you're as excited about this idea as I am, working with the deep brain stimulation and the future of care and therapy for my patient's Parkinson's disease. Until next Journal Club, thank you so much.